Hi everybody, and welcome to breakout session A for this time slot, being part of a clinical trial, pros and cons. So I'm Lori Lyons. If you weren't in the last session, I'm the Scientific Information Manager at the Foundation Fighting Blindness. And I'd like to welcome to our Vision Quest, to the podium, our Vision Quest Conference Chair, Dr. Elise Heon. Many of you met Dr. Heon this morning, but just to refresh you, she is the Ophthalmologist-in-Chief and the Director of the Ocular Genetics Program at the Hospital for Sick Children. And she is also a Professor of Ophthalmology at the University of Toronto and holds the Mira Goddard Chair in Vision Research. She's a longtime member of the Foundation Fighting Blindness community and is currently a member of our Board of Directors. Please welcome Dr. Heon.
Hi, thanks for joining us. So I don't think there's any cons in being part of a clinical trial. I guess the con would be if it's the wrong trial for you. And so the pro is that it ensures safety and it's done in a controlled way. So let's talk about why we do this. And the first thing that I noticed that means different things to different people is what's a treatment. So what's the expectation of a treatment? Like for us, sometimes a treatment can just mean to slow a disease process down. For some people would mean to improve a bit. For some people means going back to normal vision. And it's really important to clarify that ahead of time. Usually when we talk of a treatment, we would infer improvement and stopping a disease. But you need to make sure that that's clear for the situation that you're in. The second important principle that we can't overemphasize enough is first, do no harm. And I was thinking yesterday, I think the thalidomide is a good example for those of you that are old enough to remember. It shows how important the thalidomide is a good example. And it was meant to do well. My mother took thalidomide when I always say I have an overgrowth syndrome instead of, but you really don't want to be in that situation. So how do we get to a treatment? Because there's over 100 genes that cause RP, it's not straightforward. So there's some situations where the treatment will be dependent on the identification of the genetic defect, and then there's some situation where it will not. So you may ask, why do treatment need to be assessed through a clinical trial? So clinical trials are a type of research study on humans. We don't do clinical trials on animals. At least not that I know of, where the effect of a drug or a device is assessed for safety and efficacy. Safety is always the first part. In some cases, the effect of the treatment is compared between patients. In other cases, it's compared to patients who do not have the real treatment. And that's often a little frustrating. That's what we call the randomized trial, is that you pick a number out of a hat and either you receive the real treatment or you don't receive the real treatment. And at the end, everything's decoded and you compare the outcomes of those that had the real treatment and not. In situations like RP, because it's not a common disease and there's so much variability, we try to stay away from that scenario, and also because it's just heart-wrenching to have in your mind that if what you're doing is really useful, you're depriving someone from that treatment. But sometimes you're forced to do that. And so you need to decide if you want to go through that or not. So a trial is usually 4 phases. So the first phase is on a very small group of people. So that's phase 1, and that's the one that assesses the toxicity of a treatment. Usually it's a group of 10 to 20 people. And that's why for RP65, there's been several groups that have started it, but all with a small number of patients, because should there be a toxicity, you don't want a large group of people to be involved. So luckily, that was not the situation. Phase 2, is where we assessed efficacy. So sometimes you combine phase 1 with phase 2. Sometimes phase 2 is separate. And it's still a small group of people, but a little larger. Usually we talk of 80 to 100 individuals. So when phase 2 is successful and you show efficacy, then what you want is to see, well, how long is the effect going to last? So you study the effectiveness of the treatment and the long-term safety and toxicity, and that usually lasts a few years. That's a phase 3, and that's on a large group of people. That you talk of thousands of people. And then phase 4 is really when you're at the post-marketing level, is a bit what the retinal implant is at, and I'll go over that, where you include the drug risks and benefit and the optimal use. So now let's talk about the different trials that are ongoing for different treatment approaches. So we talked earlier of RP65, and I just want to go back and give you a bit more detailed, as it's been a model of gene therapy for inherited retinal diseases. The first subject in this study received a single injection under the retina in 2007. So that's already 5 years ago. So phase 1 is being completed. So as much as the young man mentioned earlier that there's delays, it takes a long time to assess these things. So since that time, there's probably 30 to 50 people that have been done in different research groups in North America and in Europe. And now children are included, and the oldest person I think that was involved is 45 years old. You usually start when you assess toxicity in adults, and I'll never forget at the previous Vision Quest years ago where a child had asked, how come you only include adults in phase 1 studies? And sometimes you wonder, is it really the right thing to just include adults? And that rule is being revisited. And so each trial is becoming a bit more different, and we try to be a bit looser on the age of inclusion rules. So then the next step would be to play with increasing the dose, the number of injection, the site of injection. Do you need to treat the fellow eye? Like, should you invest in treating the fellow eye, or is the treatment of one eye sufficient? Those are all important questions to which we don't necessarily have the answer. And the answer also relates to budget and resources. Those are just difficult situations that are being faced at this time. But we now have the evidence that such an approach is safe and can efficiently deliver a novel treatment in several patients. With 5 years follow-up, the effects is lasting in most patients. Different groups have used different constructs, or different medication that they injected. So the level of efficacy has been different. But in all cases, the effect has been long-lasting, although variable in some. So the sites that are most involved in the RP65 gene therapy trial are the Shea Institute in Philadelphia, with who we've been collaborating, the Children's Hospital of Philadelphia, the KCI Institute in Portland, Oregon, and they're still recruiting. And there's a Paris group, and I think the UK group has stopped recruiting, but I'm not sure. There's a gene that's not that common, but that's associated with severe disease, is MERTK. And this is a trial that's only done in Saudi Arabia. It turned out that there's a high incidence of individual with that mutation in Saudi Arabia. You see that with autosomal recessive disease, in closely knit communities, you have a higher incidence of the disease. So the king sponsored the trial, and currently it's only done in Saudi Arabia, But rumor is that when they're done with their people, what's left over will be shared with the rest of the community that are affected with that mutation. There's new trials that are happening that are sponsored by companies now. So there's a company called Oxford Biomedica who supports a gene therapy trial for ABCA4, which is Stargardt's disease, where they've inserted the Stargardt's gene in a different virus. And so the virus that was used for RP65 is called the AAV virus. It's a safe virus. The virus that's used for ABCA4 in, I think, the Usher 1B is the lentivirus, which is the HIV virus, but without the infected part. And so there's been concern for many years in using that virus for obvious reason. But the advantage of that virus is that it can take in bigger genes. And so far, everything's been good. There's been no side effect. And those trials are still active in recruiting. Next year, Dr. Ian McDonald, a dear colleague of ours, who has spent his career dedicated to the better understanding of choroideremia, will be initiating a clinical trial in Edmonton on the gene replacement of choroideremia. And that's very exciting. It's sponsored by FFB. There's a clinical trial for Usher syndrome, for Usher 1B. That's on track. That's sponsored by Oxford Biomedica, and which is done in England. Other trials that are being prepared include retinoschisis, different forms of Leber's congenital amaurosis, namely some with mutations in JUC2D, and so on. And that's going to evolve as the time goes. So far, in every case, there's only been one injection in one eye. In order to benefit from gene therapy, you need to have enough cells that are alive so that you can transfect them with your virus. So you need to have a certain level of visual function. The Stargardt's gene therapy trial is held in Portland, Oregon, at the KCI Institute, again sponsored by Oxford Biomedica, and you can have the information through the Foundation Fighting Blindness. So again, the Stargardt's gene is a big gene and is inserted into the lentivirus, which is inactivated. As Dr. Van der Kooi mentioned, the RP stem cells, so there's been a lot of press on for Stargardt's trial using RP stem cells. Those are just for the transfection of the RPE cell, not the photoreceptor cell, which is done in California in UCLA, or at the KCI Institute, again in Portland. There's some trials that are very important that are not gene therapy based. And there's one that is sponsored by FFB that involves a drug that's a breakdown of vitamin A that is run by a company based out of Vancouver, QLT. And the trial is done in Montreal by Robert Cunningham. And that's for those who have mutations in LRAT, which is a rare gene, and also RP65. And it's thought that if you replace that missing portion of the vitamin A, that you restore the visual cycle to some degree. There's some trial in Baltimore on RP and acupuncture. I don't know, how many of you have had acupuncture? I've had acupuncture. And so the idea behind acupuncture and RP is that it improves the circulation around the eye. I wouldn't put that's been tried again and again, and don't quote me on it, but I wouldn't go to Baltimore just for that. You can visit Baltimore, or you could get acupuncture here. So, Then there's the stem cell trials is also involved in macular degeneration. And again, the same thing is just putting the RPE cell, is not putting the photoreceptor, which is the light sensing cells. Very exciting trials that are in advanced phases are the retinal implants. So when your vision has been severely impaired, when you're at the level of light perception or maybe hand motion, but you need to have really bad vision for that, is the retinal implant. And so there's different approaches to retinal implant, and we usually talk of two different types, but there's many different groups that work on this technology. But the two, I would say, leading group in terms of published data are the German group, as I mentioned earlier, which is called Retinal Implant AG. And it's too bad because we had an access in getting some patients in to that trial. And then the German government decided to just focus on German people and not include foreigners. So unfortunately, we can't benefit of that group that has very good, very, very interesting results. But I see that they have a satellite group in Philadelphia, and we should explore that further. So the type of expectation that can be made for a retinal implant is to go from light perception to some form vision. When Jerry yesterday was talking of the reading vision is large reading vision, but it provides some contrast vision in some cases, not in all cases. So what you need for that, even though your retina is severely damaged, you assume that the photoreceptors are gone, but you still need some health to your retina so that the connectivity can go to the brain. So what it is, it's a microchip that they put either on or under the retina, and it uses the tissues that are left of the retina, which is a microchip in itself, and it sends signals to the brain. The US group, the second site, has stopped recruiting, and they're in the post-marketing phase, so that would be like the phase 4 trial, and there's negotiation if we can be a site here in Canada for that, and that is ongoing. So that's very exciting because we're developing opportunities to cater at least to different needs. So in principle, everyone's included. There's not just one subgroup that will have a treatment opportunity. It's going to be quite generally applied. So for those of you that say, there's really nothing happening, or when you always say with disappointment, so what's new? There's nothing, huh? And there's actually a lot happening, but at this point, we're really in the fine-tuning. So we're not looking at big effects, we're looking at small effects that are extremely important. I wanted to talk to you about something that's important to me is the expectations. So you need to make sure that you share with the physician what your expectations are, because the physician's expectation can be very different than the patient or the parent's expectation. And then if you don't communicate that, it inevitably leads to disappointment or frustration. So never hesitate to ask questions and to express your needs to the caregiver that you're dealing with. So I'll stop here and I'll open this talk to questions. Yes, I'll repeat the question after, so go ahead. So the question is, to have gene therapy, you need to have the gene defect identified. In autosomal recessive disease, you need to have 2 mutations identified. So you can't, because I hate to tell you, we're all carriers of many genetic defects, okay? We're imperfect. But that's what makes us different, that's what makes us interesting. But the reality is, I can be carrier of an ABCA4 gene. I probably am because it's such a big gene. I could be carrier of an Usher's gene, and it doesn't mean I have the disease. So if you have an autosomal recessive disease and you only have one mutation identified, you should not participate in a clinical trial because it's not safe for you. Now, there's limitation in the technology, and I'm happy to discuss that in detail separately if there's more questions. But the technology is changing, and our understanding of what could be a mutation is also changing. So just very briefly, when you look at your DNA, the majority of it doesn't code for a gene. Okay? We used to call it junk DNA, and we used to discard that component. We've developed a better respect for that DNA, and it in fact plays a role. When we do the mutation analysis currently, we don't pay that much attention to the junk DNA because it's huge, and the number of mutations there in proportion is extremely smaller than in the coding DNA, which is what we focus our attention on. As new technology is evolving, it will be possible to what we call sequence deeper in more detail to explore those regions better. And so the technology wasn't there to allow us to completely rule something out. So like a negative test doesn't mean you don't have that. So only having one variant, for example, in the Stargardt's gene, doesn't mean that's not your gene, but it doesn't mean that it's it. It just means that we can't confirm it at this time. So the technology is the same worldwide. It's just a matter of having the right person analyzing it. The next year is going to change a lot. The opportunities are going to change a lot in the coming year. Yes?
I have two questions. My first question, where can I put my name down if I want to be included in a trial, or for scientists, or for different therapies or stem cell therapies? Where can I put my name down for that?
So to be part of a gene therapy, as I mentioned earlier, you need to have your genetic defect identified. And a way to be identified could be to have your clinical information in your case entered in the registry, and you can do that through the FFB website.
Yes, I've done that already.
Yes. So if you've been entered into the registry, then you're therefore identifiable to participate in the trials. There's no current stem cell trials going on here at this point for photoreceptor disease. I'm not sure I answered the question, but
I have Usher's,
yes.
B1, or MIDA. I'm not sure exact the spelling, but that's what I've been identified as. And people tell me that right now they're ready for testing, but they need to have more vision. So why am I not, why can't I participate in these studies? I know I need to have more vision, but why can't I participate in these studies to prevent further deterioration of my vision?
So the studies for Usher syndrome, as I mentioned, is a phase 1 study. And because a phase 1 is attached to a phase 2, in order to see any type of efficacy, you need enough visual function so you can quantify a change. And so each study has very strict inclusion criteria. And that's what gets approved by the ethics boards of wherever that study is being done. And you're not allowed to break the rules. It's a very strict regulation, again, to protect the patient. You need to decide ahead of time who you're going to include in your study. So that is specific to that study. Yes?
Just a follow-up to that question, I believe, do all of the clinical trials across Canada all have access to your registry at the SickKids? And do they all choose candidates for clinical trials from that source alone, or do they have other sources that they go to?
So it's really all of the above. You don't dictate to people what to do. And so the registry at this point, because it's been hard to implement it cross-country, like we're very rich in terms of data here in the GTA, but Vancouver has now started and Edmonton has now started, but I wouldn't say that it's fully implemented, so the patients are not identified countrywide. Individuals have their own records, so different centers have their own records. The inherited eye disease community is a very small community, and so we know each other, and you know when there's a trial starting, and usually there's a communication in terms of recruitment. So to date, the registry's been used for the trial that's been run in Montreal, but currently for inherited eye diseases in the country, that's the only one that I'm aware of. The other trials are not ongoing. But when Dr. McDonald plans, Dr. McDonald is actively involved in the registry, and when he plans his choroideremia trial, I'm sure that that'll be his access source, because that's where the Canadian cases will be documented.
Yeah, hi, I'm Raimonda Tafilica. I have retina pigmentosa for 25 years, and I have a foot disease too, but I'm worried about my daughter, and because there's a foot disease too, but I put it, my doctor saw the eyes, and the eyes are okay. But just ask you, I need to do the genetic test, because any doctor here says me, no, don't do it, a genetic test. I asked for kidney disease, for genetic test for my daughter, because it's the same to me. I like to do it, maybe genetic test for myself and for her. Is good to do it or no?
Well, I'm a bit biased because that's my job.
Yeah,
and so
I know, you're just asking.
I'm a strong believer of the importance of having as much information on an individual as we can, so we can help you. And having a genetic test is the first thing that we recommend. You can't interpret a genetic test without having an idea of what you have, because a test in itself means nothing. So a test result in itself means absolutely nothing. So you need to have an expert see you and coordinate that is being done. So do you live in the Toronto area?
No, I live in Stoneville, and I have a specialist here because I have immigrant and I have 12 years here. Yes. And I was in Moscow before, 25 years ago, and I did tests and surgery, everything there. Yes. But now I'm seeing only for 20%. I'm seeing. Yes.
So you may go through your family doctor or your eye care provider to refer you to one of the experts. Mm-hmm. And to make sure that the genetic testing gets done and that you get the appropriate counseling.
Yeah, thank you.
Can I talk for a second? I'm talking on behalf of my mom, and she asked for the genetic test at the family doctor, but they won't give it to her.
The family doctor won't give the genetic test. I'm saying she has to be referred to an expert, to an eye genetic expert.
But where can we find that out, like where to go, the genetic expert?
Well, there's different, at Mount Sinai Hospital, there's Dr. Bakshi. At Sunnybrook, there's Dr. Coley. At North York General, the genetic counselors have been trained to deal with these issues. There's different sites now.
Okay, thank you.
I understood your point about thalidomide. I'm fortunately old enough that it was after I was born, but I saw the effects of that when I was about 10 or 12. Having said that, it seems to me like our son has choroideremia. He's about 30. Mm-hmm. And he recognizes with the clinical trials that there is a risk. But the statement about do no harm is a good statement to make. But to what extent do the researchers have input? And who actually decides on what is the level of risk that you can take in a clinical trial? Because it seems that the time from a first stage trial, and as I said in my last question with regards to choroideremia, Dr. McLaren has already started the testing a year ago. Dr. McDonald is not going to start what I understand to be the same testing in Canada for another year, so there's a 2-year gap in there. To what extent do the researchers think that the present oversight is too cautionary?
There's some things we can't control. And first, I think there's some differences between Dr. McDonald and Dr. McLaren's trial. And you can't do any intervention without taking a risk. So how the level of risk is decided is by the study group. And the level of risk proposed has to be approved by an ethics board, which includes various number of lay people, physicians, ethicists, legal people. It's a complex mix. And that's done on a case-by-case basis. So different trials will carry different level of risks. And in this case, mostly the risk is how do you administer the medication and how much do you risk a loss of vision is usually the risk that we take, assuming that there's no risk for the health. The bureaucracy overseeing the implementation of novel treatment or new devices is in fact suffocating, especially when you have a pressing needs to get that implemented. But I have to say sometimes there's a good reason. You probably would say most of the time it could have been done faster. It's totally out of our control. But sometimes there's a good reason. There's some unnecessary risks that have been stopped because of regulation that's being implemented. It's a very imperfect system. Because this approach is new, people are even more careful. So as more trials get implemented, it will be easier and it will be faster. But you need one mistake, you need one really bad adverse event, and it's going to stop the field. And we don't want that to happen.
Hi, Sina again. I had two questions. First, before the tsunami on Japan, we had the news that they found a type of the medicine that can stop RP from growing and maybe also reversing the disease. Do you have any news? Because they said it's in the level of the product that can be used by the human. And the second question you mentioned...
I'm sorry, I didn't understand the first question.
It's in the news in the Japan that they found a medicine that can stop RP from progressing, stop progress of the RP. Mm-hmm. Do you have any idea? Because it was before the tsunami in the Japan that has a problem and they stop any news in this regard. I want to know, do you have any idea from there?
So the question is that on the news before the tsunami, there was publicity of a medication that stops RP from progressing. I would say, was your question?
Yeah, it was from the Japan, yeah.
Yes.
Japan is scientific. Yeah.
So there's a trial being done in Japan, testing an eye drop to slow the degeneration of RP. It's an eye drop that's not available here. The results are not final. It doesn't stop RP from progressing, far from that. And sometimes, unfortunately, a positive result, which can be mistranslated depending on who you talk to. And so for us, for example, a positive result can be a slight improvement in the progression, a slowing down, or in some cases, then you need to see how many cases were done. But I can tell you that at this time, there's no medication that's been identified that stops the progression of RP in a statistically significant way, and that's been proven. So sometimes information gets transferred from scientists to the lay press not totally accurately. Even if it's in the Globe and Mail or even if it's in the New York Times, that's what we refer to as hype, unfortunately. But there are many medications that are being explored. As I mentioned, the repurposing of medication to see if some of these can be used, namely the valproic acid, the antioxidants, the TUDCA, and so on, to see if it can slow down the progression of RP.
And the second question is, you mentioned about acupuncture. Do you have any idea or information about Dr. Yu in Vancouver that he's doing acupuncture and using herbal for stopping RP and reversing it?
So the question, if I understood clearly, is regarding the center in Vancouver that uses acupuncture and herbs for the treatment of RP. I've requested to see the data from that center, which I've never seen. And I understand that no other scientists have been privy to see the data, so I can't comment on the real outcomes. It remains anecdotal.
Yeah, you were mentioning earlier that you have to have a certain amount of vision to be involved in one of the clinical trials. Is that correct?
It depends which one.
Okay, I have choroideremia.
Yes.
And I've lost all central vision. I have a bit of peripheral.
Yes.
I don't know if I would be able to be part of that as a participant. And if I weren't, my other question was to do with the RPE, the electronic implants. When that implant is done, does that bypass the receptors and the choroid and go directly to the brain? Or
that's correct.
Okay, so even though my total vision is gone, that would give me vision. And to what extent does that give you vision? Like what form of vision do you have?
It's the improvement of the vision with the retinal implant is very variable. It depends on the individual, but it also depends on the technology that's used, because there's different technologies. So I can't give you a precise answer as how it would pertain for you.
I see. So, I mean, are we talking like a black and white vision or colored vision, or is the
some people
the span of your vision, does that vary, or what is it actually that you're gaining through that?
So in general terms, some people have regained some color. Some people have regained some contrast vision. So as Dr. Chader mentioned, is that you can see contrast objects on a table, which is very useful. You could, anything of high contrast, like the edge of a door, which consequently improves mobility. But again, it's variable between every individual. But there's some cases where it's actually improved the functioning quite significantly, especially if you have light perception or less of vision. Any other question?
The other question that I was interested in is when you do the gene implants, do you do it on a broad span on the back of the eye, or do you do it in one spot and it expands itself, or how does that work?
Well, that's a good question. There's different techniques, and so different groups are using different techniques. So in some cases, because some parts of your retina have degenerated, so you're wasting your time putting some medication where there's no viable cells. So some group will try to identify the sectors where there's viable cells and inject there. Some other groups will inject under the whole retina and see whatever gets picked up. There's other approaches that will be to inject from the front part and the jelly of the eye and the vitreous, which you would assume have a larger span and effect. Again, it varies with each trial and with each investigator. Although the efficacy of those different approaches varies also between the type of treatment that you're using, because you want to reach a specific type of cells. So sometimes an approach will be more efficient in reaching a specific type of cell than another.
Thanks for the talk, Dr. Heon. I was reading with interest in the spring about advances in X-linked genetic therapy. I was quite excited about it, and I saw it was the RP, because Neil has RP2, and I saw I think it was the RPGR gene. I'm not sure how long this will take to come to human trials, and that's one question. And the other one, do you see it impacting research on the RP2, because it seems related? And I'm just wondering how you influence or how they make a decision on what gene they're going to be trying to advance towards genetic therapy.
So that's $1 million question. Basically what you're saying is, how do you decide what's next? And it varies on different things. It varies on funding. Some people will push funding for a specific disease, which is the truth. But in order to go to the level of gene therapy, you need to have some animal model data. So you can't just go from an idea of knowing the gene to look at it in some cells and then go to the human. So if you don't have a good animal model, that limits the progression of the gene therapy progress. So that's why RP65 was so successful, is that there was like mice, rat, dogs, there was animal models of every size that could show the safety and the efficacy. So is the fact that RP3 is getting worked on influencing RP2? Not necessarily. One is not applicable to the other because they're two different genes. So I can't really answer that with a specific question. But it's not because RP3 is next that RP2 is next in the pipeline. They don't go necessarily in order. It doesn't necessarily make sense. Thank you very much for your attention. Have a great lunch.